We hope you all had a chance to grab some of the delicious sandwiches and chips and brownies. We're going to get started because I like to start on time. I have 2 teenagers, so that never happens in my house. And I'm going to turn it over to Professor Muhammad, who will do a quick, is it noon? It's not noon. I'm just going to do a comedy routine for about another 30 seconds. Oh, yeah. See, now.
Thank you, Miriam, and thank you to all of you who've joined us this afternoon. It's a pleasure to welcome you. I am Khalil Gibran Muhammad, the director of the Institutional Anti-Racism and Accountability Project, and we have a number of people here, both from the project. If you could raise your hand, if you are working with IARA, be proud and yes, thank you, and as well from the Ash Center for Democratic Governance and Innovation. Thank you so much for supporting our work. And to our Zoom audience, thanks for zooming in and joining us. We are excited to discuss the results of our recent research project, Anti-Racist Interventions in Healthcare. I am going to turn it over to our moderator and research fellow who led this research project. So without further ado, let me introduce them. Our guest today is Dr. Vabren Watts. He is a national science, health communicator, and health equity strategist with proven experience in enhancing visibility of high-profile organizations. He's published in multiple peer-reviewed science and medical journals and authored more than 300 articles in news media outlets such as WebMD, Psychiatric News, and the Philadelphia Inquirer. Dr. Watts has a deep background in advocating for health equity for marginalized and minority populations, having served as a spokesperson on such topics for the American Heart Association, the American Stroke Association, and many others. He is currently the Health Policy and Health Services Journal Health Affairs editor. No, okay, there's a missing word there. Currently, what is your official title there? There you go. Director of Health Equity at the Health Services Journal, Health Affairs. Got it. It came after the comma. Dr. Watts received his PhD in pharmacology from Meharry Medical College in Nashville and completed his postdoctoral training at Johns Hopkins University School of Medicine in the Division of Cardiology. So please join me in a warm welcome to Dr. Watts. And we're going to start the conversation with a presentation by Angel Rodriguez, who is a research fellow at the IARA project, as well within the context of the Ash Center. His academic background is in race policy and public health. He's currently completing his doctoral dissertation in the history of science at Harvard University. Angel has published on racial and ethnic health disparities, and he is, as I said, the lead researcher on today's report. We're going to begin this event with Angel making a presentation with a deck to kind of lay the groundwork for the conversation that he and Dr. Watts will have after. Really grateful to have this opportunity. This is the first time we're able to present this research publicly, and I'll just say this research was funded and supported by the Robert Wood Johnson Foundation. Thank you. Come on up, Angel.
Yep. Okay. Thank you, Khalil. Just quick sound check. Can you hear me? Okay. Thank you. Thank you all for being here today. And especially thank you to Dr. Watts for joining us here at Harvard. I'd like to, again, as Khalil said today, present a few slides that will provide a sort of general overview of the structure of this project. We'll speak a little bit more in the details of the case studies themselves and looking at what organizations do to implement anti-racist change. Finally, we will offer a sort of general findings and a suggested framework, if you will, of how organizations can implement these changes in their organizations. So the situation we found ourselves starting in 2020 was a global outbreak of the pandemic, COVID-19, as well as a widespread reckoning of racial justice movements that really engaged and moved organizations to commit to anti-racism. From a public perspective, this was an unprecedented shift, but it also provided us with an opportunity to raise important questions around the effectiveness of such commitments at the organizational level, and particularly how this looks within the healthcare setting. To answer the question here, what enables effective and sustained anti-racist changes in the healthcare organizations? Our research scope focused on a landscape literature review of published materials in the anti-racism in healthcare, as well as a field study to identify and engage 3 organizations within the sector. The result is this report today that we are presenting to the public for the first time, and it will includes 3 case studies and an analysis of the effective mechanisms from the field to inform a series of recommendations for organizations seeking to make anti-racist change. So for starters, let me give you an overview of the organizations themselves. The 3 organizations we selected comprised of, I would say, one of the most diverse samples that we could put together. What I mean by a diverse sample, I mean that we wanted to select organizations from the community community health level all the way to an academic hospital. In order to really bring together this sample, we selected 3 organizations in the Northeast region, 1 in Boston and 2 in New York City. The first one is the Southern Jamaica Plain Health Center here in Jamaica Plain, Boston. I set some numbers here for us to look at just overall of the size in which the organization provides, the size of the population the organization serves, the general structure of the organization, and location. And lastly, that last column there is the actual anti-racist initiative that we looked closely for the report. For Southern Jamaica Plain, for example, it is a community clinic, and it is a subsidiary of the larger Brigham Women's Hospital here in Boston. Mount Sinai Health Systems, was really an outgrowth of the Mount Sinai Hospital that was started in the 19th century to today being one of the most premier academic hospitals in the country, serving a large portion of New York City. And lastly was the Department of Health and Mental Hygiene of New York City. This was a public organization and really is responsible for the 8 million lives that live currently in New York City. So as you can see, our sample really sought to include a range of organizations to really identify, evaluate, and try to understand what is working and what can work better. One more thing I'd like to just give more context here is on the initiatives themselves, that last column. So for starters, the Southern Jamaica Plain Health Center has a health promotion center within the clinic. The Health Promotion Center coordinates health equity and social justice work, really based on social determinants of health. So the marquee program within the Health Promotion Center is called the Racial Reconciliation and Healing, shortened here as Racial Rec. And Racial Rec was designed to bring together youth and adults from the community, Jamaica Plain, to engage in a peer learning practice using trauma response therapy methods. The idea here is that if we treat racism as a traumatic experience, then how do clinical methods that treat other forms of trauma might also be effective when treating harms caused by racism? Since it was established, there have been sort of outgrowths from this program, one of which we'll cover today is called Liberation in the Exam Room, in which racial rec methods were applied to health professionals and physicians. So how do physicians treat their own trauma or their own experiences with racism as a trauma effect? The second initiative under the Mount Sinai, as I mentioned, the hospital is well over 100 years old. However, the task force initiative started in 2020, but really what it sought to do was bring together parallel initiatives across the health system that had been ongoing for at least 20 years. So for this initiative, we were able to observe how a complex hospital brings together existing initiatives and is able to centralize some of that activity and demonstrate its movement towards anti-racism as a system, as a whole system, rather than just individual parts. An example of what these individual parts might be would be the medical school, Icahn Medical School, for instance, or the emergency room and other residency programs within the hospital itself. And then lastly, the New York City initiative called Race to Justice. This was really a brainchild of Dr. Mary Bassett, who in 2014 was appointed health commissioner under then Mayor de Blasio. And Mary Bassett's sort of goal was to launch a infrastructure within the public health agency that would incorporate anti-racist practices internally as a mechanism to improve public health delivery to the city of New York. That is, those are the three initiatives that we really identified. Of these three, I was able to conduct a total of 25 interviews with expert representatives of each organization. Those interviews range from board members, senior leadership, management, staff, and even interns we were able to speak with. So as you can see here, our broad range and in-depth approach to these three organizations offered us a good sample of what the healthcare sector might be doing with anti-racism at this time. Here is a data table that was published in the report. And it really offers an overview of the signature approaches taken by each organization and a general trend for understanding the focus area of these interventions. The colors here indicate a degree of applicability. So green is a high degree of applicability, yellow is medium, and red is low. And what we were actually observing in terms of applicability are these levers of change on the far left side. These levers included, for example, strategic planning, senior leadership buy-in, even infrastructure or policy changes that these organizations may have established or created in order to support these anti-racist initiatives. We can definitely go into them deeper in the conversation with Dr. Watts. The one I would like to point out is the one that all three really scored very low on, which was providing metrics and other forms of measuring the progress of these interventions over time. Now, to comment on one or two of these observations individually of the organizations is really helpful in seeing them individually and then also seeing them collectively. What I mean by that is these organizations did succeed in their initial goals to establish initiatives. The degree of that success and the effectiveness of their intervention is what really varies here. So for example, Southern Jamaica Plain was a small scale community program that we were able to show had a demonstrably positive impact on the broader Boston health sector, particularly the parent company of this subsidiary, which is Mass General Brigham. Doctors, for example, who participated in this program were able to learn from peers, learn exercising on how structural racism operates in their departments or divisions or clinics, and gain knowledge and develop strategies for finding ways to implement changes where they are based. So we followed these changes and noticed, and in the report published on how neurology and cardiology were particularly impacted by physicians who participated at racial rec, at Southern Jamaica Plain, and then went later to the hospital and initiated anti-racist changes. It is also important to note that the clinical work that was happening at Jamaica Plain really filled a gap in the medical knowledge from these physicians who stated they did not learn this in medical school. So that was a very important way to connect how community efforts can support larger health sectors, Jamaica Plain being an example. Moving on to Mount Sinai, as I mentioned, Mount Sinai had a legacy of DEI programming stretching back at least 20 years. And while it was very strong in establishing a roadmap and strategic plan for its anti-racist changes today, it was very unclear how the learned institutional knowledge from those 20 years actually translated into the new plan. Other challenges that this system saw was in the delegating of the tasks that were published in their roadmap, which really made it unclear to follow exactly who was responsible for what tasks to be implemented, and lastly, what accountability structures those tasks also had, both at the senior level, but also in the general staff and health professionals of the health system. And moving lastly to New York City, as I mentioned, New York City's initiative was very sharp in its vision for racial justice, and it was backed by mayoral leadership. This is very important in understanding how leadership is a factor in implementing anti-racism. And I think notably from this example was how the initiative was cited in 2021 with the passing of the health board, a resolution, a citywide resolution that named racism as a public health emergency. In that resolution, this initiative is front and center, and we understood that, we connected that as a way of illustrating the impact, not just internally into the organization, but how it met their desire to also improve their delivery of health services to the city as a whole. So based on these insights and the evidence collected from the organizations, IARA was able to put forth a suggestive framework, or what we call an accountability compass. And this compass is designed to help organizations in the healthcare sector specifically to think about what their journey looks like to become anti-racist, what elements of that journey can really be anchored, and furthermore, each phase of this compass is supported by levers of change that were identified in our study and incorporated in what could potentially be very helpful for organizations. I would love to say that this is unique in that there are many frameworks for organizations looking at social justice and racial justice change. Ours is particularly, again, designed by, for, and with healthcare organizations. So just to give you a quick overview, the 4 phases is chart, coordinate, measure, and sustain. We call it a compass, I think, because we're very open to this being a nonlinear model, and also open to its flexibility and adaptability to meet organizations where they are, regardless of what they've done before. So in other words, even if you didn't start from the beginning of this framework to move forward, it can still be helpful in a few ways to your organization. One last thing I'd like to say is we found in the report that in general, racial equity is measured in the healthcare system around health disparities, population health outcomes. What is less measured are organizational level changes, how those impact the employees and the services or products that these organizations offer. I think that would be the real takeaway, or I would say the real differentiating factor between our form of measuring progress and what is commonly used in the healthcare sector today. So in conclusion, our report was able to identify and engage with 3 organizations. We were able to observe, evaluate, and speak with uh, folks and representatives to really capture a full picture of what works and what doesn't. Based on our study, IARA is recommending 5 key takeaways that organizations could think about today and I guess begin to consider if this is applicable to their organization. And we are very happy to provide evidence as to why we believe these 5 recommendations do work. Perhaps one of the 5 that we can go in a little bit further is number 3, effective organizational infrastructure. I said that sounds pretty big. So to give you a little bit more detail there, here we're talking about where an organization places its initiative within its governance structure really matters. So if organizations are unwilling to provide infrastructure for these initiatives, it is likely that they will be unsuccessful. And a quote that I pulled from the report was from a deputy health commissioner in New York City who said, quote, "Understanding anti-racist interventions is also understanding the infrastructure that is needed to advance these interventions. If you talk to any organization that has a chief equity officer, you are only talking to one person." So to give you a sense of what the difference between an individual pushing DEI or equity versus an infrastructure set up to advance it. Lastly, I'd love to say our report includes an extended literature review that captures, supports, and advances some of the findings that we have in our report. Thank you.
Great, thank you. I'm going to ask Dr. Watts and Angel to grab seats here, whatever your preference.
Okay. Thank you, Miriam. Okay.
Okay. All right. So you've worked diligently on this. And I would just like to say, as I was reading this, even though like health affairs is not like a healthcare organization, like as described in your examples, it was very applicable to what we are doing to really advance our anti-racist work. It's sort of like that statement saying script, different cast. So, when I was reading this, I was like, we're doing this, we're not doing this, this and that. And so this really serves as an example for not only healthcare organizations, but for organizations in general, particularly who may be in the realms of the healthcare space, like health affairs is, to really answer some of the questions that we actually have problems on. In the last slide, you did.
I don't know if we can get the slides back.
It,
I think you can.
in the last slide, you did talk about the 5 themes in the recommendations,
That's right.
such as buy-in and continued engagement from leadership, 5 key recommendations for healthcare organizations. And so the first, I always think is the most important, because if you don't have the buy-in, you can't do others. And really going from like being in the I would say like the healthcare space, from like scholarly publishing of healthcare material, as well as being within nonprofit healthcare organizations. That is very important. And I have noticed, sort of working that field and space, some people, some organizations are very different. And sometimes buy-in, takes, hey, I present this proposal, it is passed. And other buy-ins may take over a year and a half just to get in, which really stunts your work. It can be demeaning, and it may lead to other things that were discussed in here, as far as like, turnover and things along those lines. So I really want to really start there. And, even as we try to advance health equity work, getting the buy-in from that head person, who may be a CEO, who may be the editor in chief, as in my case, is extremely important. because it really does determine how successful you will be in the work that you're doing. As you said, a shared understanding and the use of explicit language to define structural racism is very important. That's something at Health Affairs that we have done externally. But I loved, I mentioned this, and one thing I do love about Health Affairs is that we are very transparent. We know for us who are working in the DEI space that when you are a DEI officer, you're actually looking at two types of like anti-racism work. The first is external, which I always figure to me is the easiest one because it makes your organization, and looks like, hey, we're doing this, externally and we're doing a great job. But then you also have internal. And I think that internal is a lot of times an uphill battle because this your colleagues, you may get emotions involved. So really having a section to really explain why the organization is doing this, particularly I'm going to talk from internally, is very important. And that's where, again, that buy-in comes into place and really affects, like you said, long-term, the sustainability of the work that you are trying to do. I am in a room with a lot of DEI experts, and they say that internal understanding of things of structural racism is always the hardest because those are the people who are like, they could be sitting across from you, so they'll let you know. So you have to work through personalities and things along those lines in order to get to where you need to be. So that was all these are extremely important. So I'm going to say that on each one. Effective organizational infrastructure. So this is very important as well, in effective organizational infrastructure. Because the thing is, it's like you just mentioned that before we started talking, is that, you have a person who is over DEI, or like you have the department who's doing like anti-racist work. And so that department cannot do it alone. So what has to happen, you have to see like, how can we incorporate this type of work in every aspect of the organization? Like, you pretty much have to sell people on like, what is the benefits of this? For example, I'm going to give you an example. What we've been doing at Health Affairs, we have a health equity fellowship for trainees, and so it sits in our health equity department. But actually, when it comes to the mentorship, it's really that aspect sits in the editorial team. So even when we planned out like how the program would be ran, we had to incorporate the editorial team so they can have their input and ideas at the beginning to actually help sustain the program. Now, our division does not actually have to advocate as much for that program. The editorial team does that because they are a part of the solution. So really making sure that that different departments within a hospital system are one part of the problem, but they're also part of the solution is very important. So that's really important to really highlight that out. And please feel free to talk back and forth.
I would no. I thanks for that, Dr. Watts. I would say one of the things we observed in regards to the internal infrastructure is the difference between having intentions, having good intentions, and wanting the work to disseminate across the organization. And on the other hand was the lack of actual policies being passed to report on these initiatives. So, for example, the Mount Sinai case study had a great sort of system-wide initiative and wanted to incorporate the medical school, the community health wing, the emergency room. They wanted to incorporate it all. And they did in sort of like strategic planning sense. But this strategic planning never required them to actually report on what the effects are in implementing these recommendations from their strategy. So yes, the infrastructure is sort of serviceable to the initiative, but what we saw and observed holistically from the sector was the very few instances where a policy was put in place to require this to be reported, to require this to be accountable for X, X leader or X division, and that gap as a whole is where we see the report wanting to start a conversation and say, how do we do this at leading organizations, but also with community serving organizations? And I think that is sort of the specter in the room, right? Where we want these things, but in order for them to sustain themselves, to sustain beyond any individual person, are these policies that we really didn't see happening.
And that's so interesting that you say that, because sometimes I'm even noticed as you were talking, I'm seeing downfalls in our own organization of even doing that, where you implement these policies, but you're implementing them at the sort of like, hey, we agree to implement this policy, but there's no written record of this. So as you said, to really cement it in some type of documentation, would be very helpful, so that, like you said, it can go beyond the person, because we do know people leave, and soon after one person leaves, it's over 10 years that whole department may leave. So no one has that historic knowledge of how things are.
Yeah, right. And another example from our report, like to highlight on the turnover of leadership. The New York City case gave us a really good insight into that turnover, and not because people were leaving for personal reasons necessarily, but because due to mayoral changes and just governing changes of the public agency, brought in new leaders every 4, 5, 6 years. And we saw that every time that occurred, the initiative would shift, the target goals would change, and sort of the implementation or a general advancement of the initiative, even by the same name, looked completely different.
Correct.
And so it isn't always it is a turnover issue, but also in these structures like the public agency where leadership is expected to change, how do these initiatives sustain such changes without losing or being diluted or becoming something that they weren't initially set up to be?
And as you say, 3 feeds into 4. Clearly defining those metrics and then reporting those metrics, because that is the only way that I would say organizations will see the benefit of these various programs. And also, when it comes to funding, funders want to see metrics. So you have to look at it both from like a sustainability aspect as well as a sustainability aspect as it relates to like finance, of like really continuing it.
No, I'm glad you said that, because all of these organizations do have performance reviews in one way or another. Like there are metrics to evaluate the performance of the organization. We noticed that those performance reviews were rarely, if ever, tethered to the anti-racist initiatives. So there are things organizations are required to follow, track, and measure. Anti-racism doesn't seem to be one of those in the healthcare space.
And it's also said building, this is always a good one, building internal capacity and professional development. And so usually when I apply for DEI positions, the first thing I ask is, where's the support to do this? Because I think that sometimes in some organizations and corporations, they expect for one person to answer all these problems that have dated back 400 years, which is impossible. I'm like, you're asking someone to do the impossible. So you really have to give them support financially, as well as support as it relates to like allocation for staff to really address these type of questions or issues that a particular system is having. And then you also talked about professional development. Professional development is needed. I know you talked about bringing someone in, a consultant in. particularly just to initiate the conversation. I've actually been told by a mentor of mine, when you go into a new, organization, sometimes it's always best to bring that outside person in. Actually, she told me, DEI leader 101, do not do the first training for like any type of work, dealing with anti-racism or any type of equity issue. And so, bringing that person in, or sometimes that committee in, as well as sustaining just by having conversations, bringing in, as you guys are doing today, bringing in someone, a guest, to really get a different perspective of like, hey, what is going on within the equity space is key for that. So
if I may comment on the training and consulting, in our case studies, we observed that consultants, outside external consultants, were important in launching or kicking off the initiatives, in helping establish, one interview called it a backbone, help establish a backbone to the organization and where it wants to go. However, we noticed that in the long term, consultants did not really fare well, because due either to economic reasons, the organization can simply sustain paying the consultant for long periods of time, or in another case in which, for example, in New York City, the health department, they brought in consultants to train the health officers and staff, and eventually the health officers and staff became experts at equity work and started doing the trainings themselves. And so there was a curtailment of consultants. The issue there was it took the agency some time to recognize this work as to merit compensation. And it took them even longer time to create full-time positions for health equity work. And that is both on, I would say, the nature of a public health bureaucracy in the city level, in which public monies needs to be justified. So in some ways, it was a kind of indication that if New York City is beginning to pay full-time people to do this work, then maybe other public health agencies at the municipal level could sort of navigate that bureaucracy. And so it was that type of development that, again, consultants do work in the short term. In the long term, organizations need to identify how to build capacity, professional development, and compensate this work in a way that can support the overall mission of the org.
One of the with I guess the layout of the project, I thought was very interesting, is that you were strategic with choosing organizations who had these anti-racist or even equity department infrastructures, before 2020. And we know 2020 was when, there was a really heavy microscope on like health disparities, as well as the racial reckoning went on. Also, there was also a time where, you start seeing like equity divisions popping up, within a lot of different companies. And if you were in the equity space, you did receive phone calls. I would say my phone was ringing off the hook, and to the point where people say, hey, we want you to apply. And I was like, well, how do I apply? And they would say, well, we'll apply for you. I'm just like, oh, okay. So that was, a really big push to get this through. So I want to know, why did you use the, those who had a history, prior to 2020 of having like a equity framework or infrastructure?
Sure. So the strategic use of 2020 as a baseline for the study was really intentional, in that we understood the demand completely exponentially grew after 2020. But we were not convinced that those organizations coming out with those commitments actually knew how this worked, or could even provide themselves a clear path of how they were going to move. So you see a commitment from a hospital, or even professional organizations like American Health Association or American Medical Association, and the framing is there, but the practical levers of change were were invisible. They were not seen. So we chose to look at organizations that have, in other words, been doing the work for multiple years before that 2020 baseline, and could help inform new organizations or organizations newly coming to this space. Here are things that have worked in the past. Here are ways organizations have successfully implemented certain commitments, and also obstacles and opportunities, what we can do better. So the goal would be with this report that organizations starting, their anti-racist journey after 2020 could look at something like what we published and say, here's a way to get started, possibly raise further questions, specific to their organization. And I would also say, and this is where I really link with the health affairs February 2022 edition, which was focused explicitly on racism in medicine, on how our report could contribute to that dialogue that was ongoing, and really shift our understanding of health metrics to include both population health outcomes and what organizations could do in terms of organizational behavioral change.
Yes, and also one of the things that I also liked about this report is that you really talked about history, and I think this is very important, particularly during the time where I feel like certain parts of history are trying not to be mentioned at all. And so, could you just really, I guess, just talk about like the role of history in each of the three institutes, organizational entities that you researched?
Sure. I think this is a really helpful context, I would say, to engage. And when we started the research, it was very helpful for us to start with the history. I would say for two reasons. Reason one, just understanding how healthcare has spoken, engaged, or talked about racism historically. And my background is in history of science and medicine, so I was able to really contextualize exactly how racist ideas travel through time. The second use of history for us was on the institutional side, in which we wanted to understand the organization's history themselves. For example, the New York City public health department is it's the oldest in the country. So for an organization with such a legacy, how is this moment different in their organizational history? To track that, both because we wanted to see change, but also in that many organizations that do not document these histories in 5-6 years are able to recommit themselves to anti-racism, and there's very little to hold them accountable in terms of what has changed over that time. I think the Mount Sinai example is the clearest one, where we had a DEI office for 20 years before the task force initiative. And it was very difficult to see what has changed in those 20 years. So like that 20-year history. So for us, history becomes a very useful sampling device almost to really say, okay, what is different today? And then to project in the future as people look back in 5, 10, 15 years to this 2020 moment, and to say, how were we able to understand the changes in the healthcare sector space? So there's a couple different ways history played a role, and I think it continues to be something that healthcare engages with very directly, and I saw a lot of that in the health affairs edition as well, of how what changes and what doesn't. Thank you. Okay.
So I just add one thing just to add on to the history, and that was that, yeah, like you said, in health affairs, when we did do the racism and health issue, we were first just about to jump into the data, and then we said, hold up, we need someone to really describe and explain the history of racism in medicine. And so that's when we had the video with Harriet Washington, where she did who's the author of Medical Apartheid, where she did, talk about the history of racism within U.S. medicine.
That's right.
But I would just like to say this report is awesome. My team is reading it. I'm actually sharing it with a consortium of health journals who are trying to really advance, anti-racist work within the scholarly publishing space. So we will be using this as a roadmap. We're looking at the accountability compass. Really. Which starts with what chart, is the initiative strategy, the roadmap. I always think that you can't get far without that roadmap because you got to see where you're going.
That's right.
Coordinate the DEI committee, the senior leaders, and I'm going to add to that, having that those accountability partners like the organization I'm with other DEI editors and like strategists, and as well as we really have to measure the metrics, which is something that I'm guilty of not really implementing at Health Affairs. And I know we have the data because everything is tracked. So I thank you for that, for putting that on my conscience to actually do. And then, we really have to sustain to really make sure that what we are doing is published, even what we are doing internally, to make sure that is published, because people are looking how your organization works. And people also who are over equity departments are looking for answers. And some of those answers lie within other organizations and what they are doing. So I would just like to commend you all on this paper. It is a gift that will be used. So thank you so much.
Thank you, Dr. Watts. We're going to do some Q&A. Go ahead.
So we're going to open it up for Q&A now. Thank you. That was amazing, by the way. If I tweeted, there'd be so many tweets there. We have table mics, so you don't have to have a mic if you have a question. We'll just raise your hand. And we also have questions coming in on the Zoom. So we can start there. Nobody has a question in the audience here? Oh, we've got a question in the back. We'll start with you in the back. And since you're not at the table, I will bring you the mic, and then we'll go to the Zoom after that.
Because you are, I'm sure that.
Okay. My name's Ann Ryan, and I'm really interested in the second bullet, which is explicit language and shared understanding. And my question is there a public interface for the shared language and explicit understanding? The user of healthcare, in other words.
So just so I understand the question, you're asking if there's a public-facing definition for racism?
In healthcare and for the patient user of healthcare. So in other words, is this a possibility for shared growth?
So I think I know what you're talking about. So I will say that different organizations have their different definitions. I will say that there is no uniform definition of like these various languages. I do know different professional societies do have like various definitions for like anti-racism, for racism, for bias, things along those lines. And so it sort of takes, which is, now that I think about it, now that you've brought this out, it's sort of sad that there is not one centralized place where we can actually go to and really get this. So I guess that's, as this actual space, which is really new and has become more popular to some people, because this is not to negate like institutions like the National Medical Association that's been doing like health equity work for like over 100 years. But there really does need to be like a space where, you know, we can gather this information and it is consistent across the board. But then in some places, you know, it may not be applicable to certain regions, you know, of the United States. So I can talk to you afterwards about different organizations that I know who actually have these definitions on their websites.
If I can also offer an example from the report, we saw that in Southern Jamaica Plain when doctors that work in the clinic participated in this initiative, learned and engaged with analysis on racism that developed the shared language internally to the clinic. That shared language was then used in patient-physician encounters. And I would say that is an example of that internal shared understanding that starts to diffuse out to the patient population. Thank you.
So we have some great questions from the online audience. One person who also shouts out about
Oh, yeah, my hair.
can you provide an example, both of you, perhaps, from the study and from your work, by a shared
Mhm. Yeah, so the question is, can you give an example of shared language and how that has been effective in these initiatives? Is that by shared language? Yeah. So as I just mentioned on the Southern Jamaica Plain example, for instance, much of their peer learning activities are grounded in what is called social determinants of health. Now, to go deeper, the clinic itself uh, uh, adopts an awareness and uses language around racial justice and liberation to define what racism means to the local community at Jamaica Plain, how that racism is entrenched in the history of the population, which is largely immigrant and Latinx in Jamaica Plain. And lastly, that shared understanding among the clinicians is then applied in their services to the patients. So this is a really good way of seeing how doctors who never learned this language in medical school are able to then engage community and improve the services that they offer to this. And furthermore, I think, or more studies would actually start showing how these forms of shared language can actually narrow health disparities outcomes at the end.
Yes, you know, an example of that was a health affairs paper in racism and health, speaking about shared language, and really to observe like what racial bias can be. One was actually in a form of like medical health records. And so, you know, there were a couple of like words that were used to more so among Black patients as it relates to, let's just say, for example, patient denied having any pain versus patient didn't report having any pain, things along those lines, which is a paper that was published. I can't think of the name, but the author name was Michael Sun. And that issue is open, free access. So if you would like to read that paper and see the examples of like, hey, how, you know, bringing this out and like saying like, hey, this is a part of the language that can be considered, you know, discriminatory is very important. So like, I guess that's the like an example to me that could be explicit of like discrimination.
Yeah.
And using such language.
Yes, I'm Paula Walker. I'm a mid-career MPA student here at the Kennedy School. And my question is, with your research, you focus mostly on sort of anti-racism leaning institutions. And so my curiosity is, what are your thoughts about how we can extrapolate and now get some of the other hospitals and other healthcare organizations on board? So from your research and learnings, what are your thoughts about how we can extend anti-racism work in the field of healthcare?
Sure, that's a great question. I would say my favorite answer to that question is when you can utilize findings, for instance, from this report, to have a conversation with people who fund hospitals. And many of the hospitals are nonprofits. So nonprofits depend on funding from either government or philanthropy. Now, an organization such as Robert Wood Johnson could look at a report and say, well, we want to give more money to hospitals and clinics, but maybe we can also ask them to demonstrate how their health equity work is making a difference. And philanthropy may be able to tether their dollars to these types of metrics that we're talking are largely absent. If that were a scenario, I think many more hospitals and healthcare organizations would like to start leading to where that dollar is. And in this case, tethered to the health equity work. So that would be one way in which a reassessment of impact and effectiveness could lead to incentivizing more in the healthcare sector to adopt, implement, and sustain these changes.
Really great question, and in some ways motivated the nature of this project, because in the wake of 2020 and the racial reckoning, a lot of people said, what should we do? And indeed, the conversation we had with Robert Wood Johnson initially as we were framing out this project was, help us tell people the answer to that question. Yeah. So part of it is to address the inertia that exists across all industries, and in this case, in the healthcare industry, where people express goodwill and good intention, but don't know where to begin. And so now we want to eliminate that barrier to getting the work started.
Got it. Thank you.
Go to the Zoom, and then we'll start questions. We'll finish up. Great. I'll combine a few of them online, and then thank you for those. Red on the chart in terms of metrics, et cetera. So there's, as this person notes, a tension between wanting to engender a learning environment where mistakes can be made, but still having accountability for making progress and avoiding doing harm. So can you both point to either some examples or how, given this body of work, you would approach things like performance appraisals or just other general examples of metrics for thinking about monitoring internal organizational systems and processes?
Great question. And it's a question that gets asked, I think, very, very often. I can start by saying some of the things that organizations do measure, and I think are effective in the sense of expanding their employee base with people who identify as people of color, Black, Brown, Indigenous. So that is sort of the go-to metric that many organizations point to in terms of saying we're implementing anti-racist in our organization. Where I think those demographic forms of metrics are limited is that they really focus on individuals and less so on how organizations are either behaving or changing or implementing infrastructure or allocating resources to specific activities that have more of a long-term impact. I think this also raises a question that if most of the healthcare sector is struggling to measure at the organization level, what kinds of new innovations, research projects, or collaborations can we foster in answering that question a little bit more directly? And like you said, Dr. Watts, bringing in accountability partners from the sector itself. So I think it's both a finding for us as much as a cause to do further research.
Yes. With that, I want to sort of begin with that. We do, the first thing is to really acknowledge, which you mentioned in the paper, to acknowledge the actual problem. And I'm only going to speak on from scholarly publishing. With like this, for example, within health affairs, we are scholarly publishing entities. So we begin with authors, reviewers, and editors. And so one of the things that we really had to do was really look at what is our racial demographics as it relates to like our authors as well as our reviewers. And so, what we found, some of the data, we did find that like almost 70% of our authors did identify as white. And that's something that's not new. That's something that we have published in the past, within the last 3 years since I have been there. So we really have to look at, like, we have to start with the programming of like, well, what can we do to increase diversity among those authors as well as the reviewers. So that will require us to continue to collect data on that. And so when we did do the racism and health issue, we were very strategic to see like who was actually publishing. And I will say that 70% of people who did publish in the racism and health issue did identify as a minoritized group within this country. But then not only did we look at that, which is a high percent for people who publish within health affairs in that one issue to represent that large number of minoritized groups, but they also in that issue also 70%, well, over 70% represented people who have never published in health affairs, which I think was great when you sort of is not by by happenstance that that those two numbers sort of correlated with each other. And so like that could be used as something with like metrics, but not only do it for the racism and health issue, but other issues as well. And then, we are looking at like following up to see like of those who have published, within various, well, for example, let's say the racism and health issue, are they being asked at the same rate to review? Because we do know that when you review something, when you put your input in something, you do bring in your experiences just because it is a part of your life. And so, and even when you write, you bring in those experiences. And so you may have, reviewers who may identify with something, that you are saying. And so, so when we talk about measurement as it relates to like scholarly publishing, we really have to look at, hey, who's publishing, who's reviewing, and really take it from there.
Right. And just to add on to that question, which I think was great, is the other part of this the other part of this lever is metrics and reporting. And so one of the things that we could look at is how is discrimination being reported at these organizations, and what is really being how is the organization being transparent about such reporting? We know universities have Title IX offices that are designed specifically to report on gender discrimination. There may be room for some similar type of structure that can report on racial bias and discrimination, and that is entrenched in the policy fabric of the organization, such as the university. So I think these are the absences that we noticed in the healthcare space, but certainly have precedent in other sectors that could also work here. So that would be the metrics and reporting sort of recommendations that could work. But other than that, yeah, we're happy to keep engaging the conversation after the event, and just want to give another thanks to Dr. Watts for joining us.
Thank you, I enjoyed it, and thanks to you for writing this.
Sorry, we'll have you come up and ask your question then afterwards. So thank you very, very much. I don't know about y'all. I thought this was amazing. You guys were amazing. Thank you. A few things. We just want to let you know that there's a Spanish translated version forthcoming for this report. So keep an eye out on our website, which you can get to if you scan this fabulous QR code. And the full report will be available if you scan this fabulous QR code, hopefully by the end of the day today. And also follow us on Twitter, provided Twitter still exists, IARA_HKS. And please join us for our next events, Cannabis Legalization and the Fight for Racial Justice, which will be an IOP Forum event on April 12th. And the final series in this Changemakers event, April 27th, Why Do So Many Organizations Stay White? I think we might have some ideas. All right, thank you very much. And please feel free to kind of come up and continue the conversation